we're going to be talking about sociocultural factors in this group. And you all have seen this video, I'm sure. You may lie on different sides of the divide in terms of what your opinions of this video are. This is Z-Dog talking about moral injury. He makes some good points, but I think he maybe takes it a little too far. But we do need to become more involved in our expectations, in how our society interacts with us, and how we interact with society. So we need to look at some of these issues. I'm not for or against necessarily Z-Dog. I'm just pointing out that recently we all saw this video. And we are the social and cultural group. And you can see we're one of the other external factors. And there are a couple internal factors that are the blue. And again, we started out and there was a different motto on name that was slightly different. And it has changed since then. So our conference just kept moving along with that. And we keep moving ahead. So what we'll be talking a little bit about are alignment of societal expectations in clinician role, culture of safety and transparency, overt and unconscious bias and discrimination, a little bit about media portrayal, some patient behaviors and expectations, political and economic climates, social determinants of health, and stigmatization of mental illness.
I'm sorry, it may just be my age of years, but we either need the volume turned up a little bit or for you to speak closer to the microphone.
I can, but I keep moving. That's the problem. Okay. All right. I'll try to stay still. Is that better?
That's better.
Okay. All right. Our leadership in this committee, we've already introduced ourselves. There was one other person, Deb Paulson, and she worked diligently with us, but from the beginning we knew that she couldn't come to this conference. So, but I did want to give her some recognition. All of these people, just like all the people on the steering committee, have worked very hard and gave opinions, and we've bantered things back and forth. So it's been a great group to work with, and I've been very fortunate. Okay. So this is what we're going to do today. Jay, on the table there are some lit searches and some breakout session agendas, and we're actually physically going to hand those to you. The literature citations are, if you want them, fine. If you don't, that's fine too. And then the breakout session agenda is just so that you can have it right in front of you. What are we doing? Because we're going to bounce around a lot, and I want you to be comfortable with what we're doing. We thought if we just threw a bunch of new things at you and didn't tell you what we were doing, it would leave the group completely discombobulated. So we decided to go ahead and print it out for you. And we'll each be doing different parts. My part right now is to review the topics, but then you're also going to get a handout with these topics on it. So you don't need to document. You're going to get a handout with this, and you can take some notes. I'm going to speed through the topics that we're covering and what we know a little bit about the research, and then we're going to hand them out to you on a handout. And you're going to look them over for a few minutes without us talking or bothering you so that you can think a little bit. So if we talk about issues and problems with societal expectations and the clinician's role, sometimes patients do have unreasonable expectations or unrealistic expectations. The fellow with the back pain for 5 years who comes in with his back pain and wants an MRI now, today. What's different? Well, I'm tired of it. Well, that's an expectation that, I'm sorry, but we can't meet that. The person that has a whole lot of problems, and I sometimes say that I'm a holistic doctor because those are the ones that seem to get funneled to me all the time because they know that I'll sit and talk to them for a while and try to figure out why they're there today. But we have to sort of make sure that patients know that we do have some limitations, what our job is, and that we're human. We also need to go to the bathroom, get a drink of water, sleep sometimes at night. And sometimes we kind of forget ourselves that we are human and we have human needs and desires also. And sometimes just frequently reminding people and reminding ourselves. I think if you remind yourself, it helps other people understand that, yes, you're human and you can't do that. The hero syndrome is something that we hear about where, we've all grown up in various ways, have come to medicine, and we're kind of the family hero. And so now, how do we deal with that? Because we really are not heroes, and we need to firmly make people understand that we are not the heroes. Some solutions for unrealistic expectations are to draw the patient in with shared decision-making, We give them effectively a ride-along, which was the name for our topic. We're going to explain to them what's involved, what we're doing, and why we're doing it, and why we're not getting a CT scan on that young child with the head trauma, because we don't need it today. And these are the reasons why. So we have to share information to help patients come to our world a little bit so that we can more effectively interact with them. And we also need to repeat that we are human and we have some limitations. I think if you keep that in mind and don't think of yourself as this five-star hero, that you're more likely to take care of yourself because you consider your needs too. We also, in the terms of safety and transparency, we need to think about the safety of patients in our department as well as our own safety. And we also know that errors associated with burnout are well known, and we don't really need more studies to show that there are errors associated with burnout. Some of the solutions are that sometimes physicians are afraid to indicate that they are having some health or burnout issues because they're fearful of retribution with licensing boards, educational, professional boards. They all have to be part of the solution on how to balance health and wellness with the physicians, with that of the patients. So it's a balancing act. Sure, the patients have some right and entitlement to having a healthy, compassionate provider, and we have some obligation to provide that. But the physician who perhaps has a medical or psychiatric problem and needs some help should not be penalized or punished by some medical boards just for being human. 10% of the population at any given time is depressed. That's going to happen in physicians too. Again, we're not heroes. We're not superheroes. So what we do need probably in this area are some studies to show that burnout improvement reduces errors and reductions in work effort, which is kind of when you're burned out, you're just not real enthusiastic about working, so you move a little slower, you process a little slower, and you're just not happy. Or you are very superficial and just blow people off and don't address what they came in for. We have turnovers because of burnout, and that also is sometimes a safety issue. And then you have the penultimate issue of substance abuse and or suicide. And so we have to have some easily applied evaluation studies to look at burnout, but we also need to show, I think, that when we reduce burnout, that people can be more successful, again, in caring for patients. And then one other thing that's also of importance, I think, in this whole, it seems like it's a little bit out of place, but it's really not. We have to find out some way to decrease interruptions, because that, to me, that's like where a lot of mistakes happen. You're in the chart, you get interrupted. You know, the studies show 10 times an hour. I think it's 10 times 10 minutes. You know, it's like 1 a minute minimum. But when you're in the chart and you're doing that thing and you're putting an order in and you get interrupted and you come back and you can't remember what you were doing, it's not a good way to take care of patients. So we have to figure out some way to decrease the interruptions and the noise in the atmosphere and the environment. We also have the topic of discrimination and overt and unconscious bias. And we do know some things, that female physicians are paid less and are less likely to be promoted, although that is changing. It still is a fact. Probably has less to do with gender than with social or societal issues. Typically, not always, but typically it's the female who stays home and takes care of the children more often, or cleans the house, or does more of the housekeeping duties. And I don't mean that as an insult to any males in the room who actually help with things like that. It's just by society that tends to land on the female shoulder. So we don't take into account sometimes, and women try to short sell themselves with their ability to lead and take charge in this setting. There may be some discrimination against women in the workplace. Sometimes, I don't really feel this with my colleagues, but sometimes with consultants you get a little sense of that. And then there's actually, recently was an article about female nursing versus female physician discrimination, which unless you're female and have been at the target of this, you might be a little hard to understand, but it does happen, and it's kind of, sometimes it's subtle and sometimes it's very obvious. And you know, my solution for that is always just work through it, and it'll go away if you just show them that your intentions are good. But sometimes it takes a little bit of resilience and stepping back from the situation and looking at it and saying, okay, I'm going to make this person like me, and I'm going to work with them. There is also evidence of sexual discrimination or harassment, so we don't need any more studies to prove that that happens, but we might need to look at gender disparities and rates of discrimination via some regular anonymous surveys, have some way of monitoring that in the work environment, And we also need to have a culture of zero tolerance for workplace discrimination and safe reporting mechanisms. And we also need to ensure that institutional systems are in place to ensure equality of pay and benefits while we take into account the specialty, the experience, and the productivity. There also is an issue of implicit racial bias, which can lead to health inequalities and abusive treatment, even at times, stereotyping, maybe not giving pain meds as often as we should, and lack of quality in care. There are sometimes some implicit attitudes that are more significantly related to patient and provider interactions that are related to racial discrimination. So there is bias in medicine. We need to just recognize it. We don't need more studies to show that. We know it's there. What we need to do is make ourselves aware of it in time and also have a culture of acceptance for all racial groups and ensure that policies are in place to encourage acceptance and equal treatment. And we need to educate and bring to light as our learning students and residents are present, just model how to treat people in a nice way. You don't have to be a rug, but you have to help people be polite. We also looked at media portrayal, and this was one of the topics listed in the National Academy of Medicine website. It's kind of an interesting thing. Patients get their opinion of what we do from TV, and there are ethical issues portrayed, and there are mistakes, burnout, death, dying, lying, cheating. The whole assortment has been on TV. And so this is what patients see. So you need to keep that in mind and again, explain your work environment to people. There is the cultivation theory that says that what our exposure shapes our attitudes towards real social reality. So again, always keeping that in mind. But we also thought that there's not a whole lot that one can intervene here in terms of research other than maybe using these vignettes to teach. Use the vignettes to teach students, to teach residents. Maybe using physician burnout vignettes and discuss that with the residents and students. That way it's, you're talking about a problem that they are not familiar with the person, and maybe they can have some insight into what goes on with burnout. In terms of patient behaviors and expectations, we all know that the risk of violence is 4 times more likely in the healthcare industry. If you look at the 2005 Kolenko study, they talked about violence in the emergency department. And then there was an Annals of EM abstract in 2018, which compared the violence, and there essentially was no change from 2005 to 2018. And yet, in spite of that, between 2005 and 2018, there was more security in place. So what's going on there? Are we allowing people to behave badly and just tolerating it? There are some solutions in, believe it or not, OSHA.gov, and those are helpful places to look for some ideas with how to deal with violence in the emergency department. One of the other sessions has this topic per se, so I didn't spend a lot of emphasis on this. So we don't need more studies to show that there's violence. We know that. We want to know what patients want and also how to protect ourselves. So we can do that all together in a synergistic way. They want the best medicine. They want to know that their doctor is highly qualified, but they don't want statistics. They want a testimonial from other physicians or testimonial from friends, or I guess they go to Facebook or whatever, but they want it that way. They don't want it in the form of statistics. And they also want to know that third-party coverage is always available, and they want to pay as little as possible. They want treatments that will require little effort. Take a pill instead of change your behavior. So we have to deal with that concept a little bit and just kind of gently nudge them along the pathway to wellness. They want timely care by an empathic provider, and that's definite. So if you can, anything you can do to improve eye contact, sit down at their level, all the things that we learned about as medical students, and then we get in a hurry in the department and forget to sit down and talk to that person. And it just gives them such a sense that you're their only concern at that moment, however long that moment lasts. We also have the issue of political and economic climates. Remember that if you have burnout, many physicians leave when they get burned out or they retire early, and you lose that person who has had all this training and has the ability to help others. There's an incredible replacement cost. There's recruiting, and then actually the bargaining, and then getting the person there and getting them up to snuff. There's a lot of time. So we know that that's a fact, that it costs a lot to replace a physician. We need to increase the awareness in terms of people who hire the physicians, that, look, if you improve the environment here, you'll improve retention and you'll improve patient care. And the other thing that came out of our looking at things are that productivity assessed only by RVUs is not necessarily the way to go. We need to have some measure of patient quality. You know, we're all in medicine for a reason, and we believe that we want to care about patients, and I believe that we do. And so we want something that actually measures quality of care rather than just RVUs. So we need a qualitative component to make us feel happy and to make us feel connected to patients. Okay. Other political and economic climate issues, ever since the act which established our medical electronic charting in 2009, we've kind of lost some autonomy. So we need to figure out how to get that autonomy back. It's difficult to address on an individual level, but we can address it by the electronic medical record, patient satisfaction, measurement guidelines, healthcare costs. So we need a consensus opinion around the exact definition of this particular factor, because this was a very difficult subject to look at research on. There's almost none, and a lot of the things that are mentioned are not really possible to change at our level, at an individual level, but at an organizational level, it is within the realms of grasping. And then we also want to advocate for busy work for physicians. We don't want that so much. And we keep fixing systems or problems by adding more documentation issues and adding more things for the physician to do. In our own department, you know, we have the basic patient care flow, and then every time there's a problem, we add another thing for the attending to do. And it just keeps adding and adding and adding. It's like, can I see some patients, please? And just let me see the patients. So we need to think about that. Our solutions need to not make more work for the physician that doesn't really have an impact. And we do need to get some consensus statements by national organizations on burnout. Social determinants of health, very interesting topic, but unfortunately it is another topic that probably we can't fix a whole lot. There are 6 social determinants of health, and they, you know, the patient who comes in who is homeless, who has no food, who wants a lunch, who has no shoes, who has poor education, has poor healthcare literacy, those are overwhelming at times, and at times we end up feeling like we've gone from the lone hero to just alone, trying to help this person, and you can spend a lot of time trying to help one person and have them show up the next day with the same problems. So we really need some downstream fixes. That's the only way to fix this problem, is to look at issues downstream. Try to help out with the issue of drug addiction. You know, there are things that we are now starting to do in the emergency department with opiate withdrawal. Let's be advocates of that, because we may help some of the downstream problems that we're seeing in the emergency department. But we need to probably partner as groups and try to fix the downstream. This is social determinants of health issue. Another category that was in our grouping of sociocultural issues is the stigmatization of mental illness. And again, there was a convenient sample of physicians who reported reluctance to seek formal medical care, and mood disorders go untreated. We've all seen some people who are just like burned out, crackly, crispy crunch, and you can pull them aside and talk to them and try to befriend them, but they really need more help than we can offer. And I understand the lack of willingness to seek help, because you will then be put in some program and everyone will know your business and you will have to report to this person, you know. So we need to do things that try to say, hey, these physicians have some legitimate needs, they're legitimate people, and work with the boards, because if we just mandate that you can't do this or you can't do that, boards of medicine are not going to comply with that. There's just going to be conflict and we'll make no resolution. But if we work together to find a way to make it better for the physicians and all providers, then I think that we will have accomplished something. We will have programs to discuss physician burnout in the residency, and we already do that, have been doing that for a long time. I recall back before it was popular doing these lectures with residents, and they thought I was just nuts. And now they still think I'm just nuts, but you know, I think I'm having an impact. But do the programs, if we improve someone's burnout status, do they decrease stress? Do they improve emotional exhaustion? Do they improve the person's ability to regulate their emotions? Do they improve work engagement and job satisfaction? Because the opposite of burnout is not happiness, it's really engagement. You want people who are engaged in the care of patients and engaged in their own lives. In terms of stigmatization of mental illness, our primary strategy to reduce employee stress has limitations. Like if you can add all the mindfulness and yoga classes and meditation classes that you want, but that alone has a small impact if you still have a toxic environment. So you really have to look at these programs that are available and are they effective. We have shown, there are several studies out with mindfulness and various types of physicians, and it does help, absolutely. But how effective are they? Is there any way to decrease the burden of the electronic medical record to improve stress and wellness in the practitioners? These are things that you have to go to the the C-suite or administrative people and say, look, if you cut down this over here, this activity, we can help over here. So you have to be willing to give something for that. But we need to know, if we do all these things, will we then have well physicians, or will we have physicians who say, okay, this is better, but we want blah, blah, blah. And I don't think there's anything wrong with constantly striving to be better, or a Kaizen concept, but I think that we need to also set some goals and work for them. And we also want to know, how does physician well-being impact patient care? And I think we do need some more measures of that, although there are some out there. Okay. So again, these are our topics. And just looking, media portrayal and social determinants of health, we kind of put on the back burner unless someone has some amazing idea, because we realize that we can do very little as a person, but these are more, they are system issues, and they are things that we need to address as a group and show our forces in numbers. Also, political and economic climates, not that there's nothing we can do, but there's a paucity of research in this area, so that's something that needs some creative work. And this brings us to the next section of our breakout session, which is a just-in-time individual reflection. And Erin is going to give some handouts. And also, we're going to take, how are we doing on time? Are we good?
Rosanna,
yes. Okay, all right. He has a different handout. Are we good on time? Moving along, okay. So we'll take 10 minutes and have you just look through these. These are basically slightly longer versions of the slide here, and you can look through them and actually take some notes, or maybe start writing down some ideas of what you think some interesting research areas might be. So I thought if we handed you the actual physical copy, that you could write down notes and you can take it home with you. It serves as a reminder. So again, I'm a person who likes lots of job aids. I like to hand out.
You mentioned media portrayal and how you kind of put that on the back burner. But when I was growing up, how were doctors portrayed?
Marcus Welby, Ben Casey.
Marcus Welby and Ben Casey, who was one of my heroes, and Dr. Kildare.
Yeah.
And now we have House, and we have Nurse Jackie, who's a substance.
Yeah.
Has a substance use disorder, as does Dr. House.
Yeah.
I remember a study that was done that looked at how doctors are held in regard, and they compared doctors and compared nurses and compared the post office and compared congressmen.
How about used car salesmen?
Yeah, well, and I don't know that I've seen one of those lately, and I don't know where physicians are on that, and I'm wondering if that's something that might be interesting, because one of the things that we hear all the time, that I hear from young physicians, in particular young women physicians, is I go in and see the patient, and then they ask, when am I going to see the doctor?
Mm-hmm.
And so what are the things that we can do with regard to that, and whether we've done any research on that, and should we, particularly with regard to emergency medicine, should we do some research, for example, on what can we do to raise the regard of young women physicians in the minds of our patients? Just a thought.
Yeah, those are all good thoughts, and we'll have some time for those because we want those thoughts.